Thank you for the introduction. And good evening for all of the participants in this discussion. So the objective of this presentation is to outline the linkage and to understand the items of the health financing information system and the healthcare payment models. So I start with the insurance model to remind that how the health financing come into our discussion today. Since universal health coverage is the ultimate goal for the countries to provide protection of health service to people in the country, or as they become ill, then become as patients. This is in the block A, and service providers is the B. The A, when used service formally before the universal coverage, they pay the direct payment, but after the universal health coverage, then the countries will collect either premium or tax as the insurers. If collect tax, then it's become the beverage model. If if the insurers or the payers collect the premium as the contribution, it's as the social insurance, social security. This is the model of the payer or the funders. And once they have a financing pool, they allocate the budget or they set the payment rules to the provider according to the agreed service items that they arrange, or the design, the essential package for the countries. And within this, we have the element D, which is the government or professional bodies that may use the information from these elements, A, B, and C, to evaluate whether the insurance model works for the most efficient and most equitable with the most highest attained quality of care. And this just remind you that the sixth building block is the essential six elements to think of for the health system service delivery, as the insurance model will define what service delivery are covered. But today discussions will focus more on the information that has to be the foundation of the items that provide by the universal coverage or the providers. And the financing, which is the payment models that we discuss today. This is to achieve health, level of health, the highest attainable level of health, and also the distribution to all segments of the population with the responsive and the social and financial risk protection, and with the highest efficiency of the total health system. This slide, I got it from Dr. Bunchai, chair of the AHIN. Yeah. So this is the linkage. So this evening we discuss mainly on the in the linkage of the healthcare delivery and the health financings and health information technology. As the payment model, I take the materials from the latest OECD health working papers last year, 2023. We can, this diagram show that the provider payments for primary care and the outpatient specialists across the OECD countries, of which they have about more than 30 countries, the member of the OECD. We can see that there are many alternatives of payment. This one is the capitation, and it can be the mix of the payment method. Like in the UK, in the majority use the capitation, but it combined with the fee for service and combined with the pay for performance, as the agree performance to increase a quality dimension. And in some countries may use the global budget. Like you can see that about 9 countries of the OECD use the global budget for that. This is the primary care, which is the non-hospital. It's outside hospital setting. But for the outpatient specialists, which mostly related to the hospital, ambulatory hospital visit, they can set the payment as the fee for service, as the pay for performance, and global budget can also be as well, and some others payment methods that is suitable for the context of each country. So we have we can see that the most popular use is the fee for service, because it has the connotation of increasing the service as the signal to this kind of payment, fee for service. It's most traditional. It increased utilization, but the drawback is it may increase the expenditure that cannot be controlled. Next slide is the yeah. This slide is the provider payments for the acute care, and the dimension of bonus payment. For acute care, it covers the inpatients, inpatient acute care. Then we have the most popular is the payment per case, DRG or DRG-like. There are many countries, 14 countries that use this. Another option is the prospective global budget by 13 countries, and the payment based on procedures or service. There are 2 countries, or the line item budgets. This is the rather traditional. There's only 1 country, because other countries try to make the payment to the providers away from the supply side. And for the bonus payment for the specialist can be arranged for the primary care service or the specialist in about 8 countries. Yeah. We can see that these slides show the innovative provider payment model for promoting the value-based health system. This is the title of this working paper. So at the conclusion of this documents, the keyword is that start small, prove value, and scale up, because there are catchwords that very fashionable, that we have to use the terms that to promote the value-based health system. But from the experience of OECD countries, after looking at the literature, the evidence that published, the value-based model requires a lot of information on the payment, information on service delivery, and maybe link with the information from the health workforce. That means who provide the service and the outcomes. So value-based payment model which target acute events. Acute events, there's I highlight this term, that the episode-based bundle payment, since the earlier 2 slides say rather separately about the outpatient ambulatory care and separate with the inpatient care. But when we think of value-based payment, some of the alternative of innovative payment model is the based on episodes, and episodes include the outpatient investigation before the major operation, and payment for major operation, and follow with the follow-up service, which can be the ambulatory visit at the hospital. So the term use of episode bundle payment is more complex, combining with combining services for a certain of time and a certain of setting. So if we look at the evaluation that try to present the impact of the episode bundle payment model on the impact on the health spending, the impact on quality of care, and the patient experience with care, they found very little evidence that episode, and they come to the conclusion that episode-based bundle payment for surgical care, rather more solid evidence than episode-based bundle of care for medical care, payment for the medical care, such as the cancer or the DM, diabetes, like this. There are some evidence in the United States, in the US, that the BPCI is the bundle payment for care improvement or the comprehensive care for joint replacement, CJR. So compare with the CJR, which is a kind of bundle payment, episode bundle payment for the surgical care. Rather clear that they can save the spending. The impact is better for if arranged in this way as the episode-based payment. But the effect on spending is not conclusive in terms of the bundle payment for the care improvement, such as the DM or NCD, chronic disease management. In the example of in Canada for the integrated funding model of the sick pilot projects that can prove positive for 3 dimensions of spending, quality of care, and the patient experience. The situation in Thailand, this slide is also the that I borrow from Dr. Bunchai, that these slides show the linkage, more linkage with the 6 building blocks, not just the 3 dimensions of service delivery, the information and healthcare financing system, but it's linked with the healthcare workforce and the medical product and and the leadership and the governance. So if the information capture all of this from the previous slides, that if we think about value-based healthcare, we rather, because of a scant information that lead to the good conclusion, if you want to prove this, then we have to design the information system and the service delivery system, and including the payment method that facilitate the increasing return on value for the health system. So information layout is very important. This slide shows the schematic of the standard data set that we think of 30 years ago when we start exploring about the universal coverage and start to think about the information for DRG, which is the main method for payment for inpatient care. So the linkage of information and the sending of information, the analyzing of information, and the use, the analysis for payment are very essential for the managing the universal health coverage with the payment models. And having present to you about the new innovations like the episode based payment bundle and complement with the fee for service, complement with the bonus payment, pay for performance. So lots of information that this first version cannot cope with. The over 20 years, almost 30 years about research on the DRG and put into practice for over 30 years. The DRG payments still going on, and capitation payments still going on. But the management of universal coverage and payment of the National Health Security Office in Thailand, they create a lot of management initiatives to cope with the complex system, such as the example of once we provide the universal coverage, and that means the cataract surgery is also free with the lens insertion, and many backlog of the previously that we don't have a good system. Then once we provide with we want to clear the backlog. That means patients waiting for cataract surgery. Instead of using DRG, the NHSO create the central reimbursement that for certain cataract surgery, they will pay with the case-based payment outpatients instead of inpatient. So this is has to take a portion out of inpatient budget or the payment by DRG. So there are a lot of other initiatives to pay for like emergency service that can go anywhere. Yeah. Then they set the fee schedule for payment, and soon afterwards there are a lot of kind of services that want to promote, like long-term care, rehabilitation care, subacute care. So this is they use the fee schedule, and and furthermore, the populist policy that try to provide a free choice. As some of you are aware that in Thailand, universal health coverage managed by 3 different schemes for the 100% of the Thai population. So some scheme provide free of choice for outpatient service, of which the scheme that impose the gatekeeper model. That means I had to use the primary care family doctor before going to outside the network. This is a limitation of the scheme that use the gatekeeper model. So they want to win more popular vote. Then they provide the policy that with the national ID card can use service anywhere. So this come for the pressing pressure on the tools, another tool that we have to use. We have to create the per visit outpatient case mix payment model. And the drawback of the one ID card can use service anywhere. The drawback is the fragmentation of using health service without the good concept of the family doctor or family medicine. So the integrated care is the another terms that have to flag up that we should think of the information or the payment models or the advance in the information technologies that can assess the integrated care. Yeah. So integrated care can be tackled, should be tackled at the good quality digital primary care system. This is a challenge, future challenge for to be delivered or should be discussed after the talk that can we achieve this challenge to provide integrated care with the good system of IT, with good designs of payment models. So a lot of research or a lot of capacity building of human resource and the infrastructure is needed to undertake essential research to drive the better health system, desirable health system. Like the eminent agenda in Thailand that we had the workshop last month about the outpatient case mix, which there are lots of literature that we can review that the payment for outpatient service can be the person-based, the capitation adjusted, risk-adjusted capitation, of which they require information that may be that the first version of standard data set that we think that I present to you the earlier that cannot cope with. Then we have to think about designing the information system. If the one ID card can use service anywhere, this the payment per visit outpatient case mix can be the alternative that they use information that can that had to locate the location of service, the mode of coming for service, whether it the first outpatient service or the follow-up service. This information need to be in place. Yeah. So this case mix, we have the define of the granularity of homogeneity within a group and heterogeneity between the group that we can use for allocative efficiency. So this slide also from the paper that I wrote with the Dr. Bunchai, that flagging about the standard that if we for the complex or for the ultimate goal of analyzing for the fragmentation of services that that patient can use service anywhere. The data should be interoperable. So the concept of standard has to be developed for the data items that we have to use. and that the HL7 fire is the aim that we have to cover all kind of data warehouse. Discussing about the integrated care concept. When I search for the integrated care, and I would like to see the cost of integrated care, and luckily I found this reference to the year 2024. Early this year, NHS England can provide the account, and this is the approved account of the within the NHS, the year of 2022 to 2023, and with the line of the integrated care boards, the expenditure of integrated care specified by the NHS. They just start from 2021, 22 to 22 to 23, and then they can shift and can better define that this is the cost or the expenditure of the NHS that is catered for integrated care. And with the cost and with the outcomes, then we can assess the value of the design and the operation of the health system. So this I put this as the, if you have a good structure or the good standard of the also in the account system, we can present whatever the policy and very timely presentation. So that's my thought for you for this our discussion. Before I end my presentation, so from this presentation, what are the keywords of your most concern? You can type in with the scan of the QR code. You can type in as many as keywords that you would like that you heard from my presentation, or the keywords that you expect from my presentation, or from whatever that related to our topic today. Yeah, thank you. Start.
I put several phases, but it come to kind of the only words. So it seemed like the Salidos only chopping the phases. Right? I've used the digital primary care system, but I use like the bundle
payment,
bundle episode bundle payment system.
Yeah.
But it's kind of the chop into several words.
Yeah. Okay, times for discussion.
Thank you for presenting Thailand's health financing information systems and healthcare payment models, Professor Supasit. Now we would like to open the virtual floor for questions. To our participants, you may type your questions in the chat box or in the Q&A box. Or if you'd like to speak, please use the raise hand button so we can call your name.
Salof, do you and Dr. Alvin, do you have any comments on the relationship between the health financing system and healthcare and the information system?
Thank you, Dr. Bunchai. I just posted a question in there as well, and it was really great to see Dr. Supasit also presenting the triangle, of health information systems, healthcare service delivery, and financing. And in your experience in Thailand and other places, like is health financing the way to incentivize digital health? Because this is what we see in many countries. We have the frameworks, we have the tools, we have many people understanding it, but it seems like incentives are what is missing. And is that the next? Is that the way to really push for digital health reforms, to tie it very closely with health financing, and say, digital health is therefore incentivized, and it is pushed throughout the health system?
So it's the keywords, but we as the community have to prove that it should deliver in that way. It will be a more efficient management system.
Salov, with my experience, I come later. Dr. Supasit is my mentor 30 years ago, and he created the dream that we should have the information that can be served for healthcare, and also can be used for the provider payment. Because of Dr. Supasit is the creator of the Thai DRG. So at the time, to me, I think the three triangle, you cannot the three component in that triangle, you cannot separately working. You have to design together. The success of the Thai DRG, the use of the DRG to incentivize provider to adopt the DRG system is because of we reinforce the use of the health standard data set at the first place, and enforce to use the diagnosis ICD for diagnosis and the ICD-9 for procedures. Another lesson learned that we found in the last 10 years that when we starting to pay like fee schedule or the fee for service with line item, the standard of the drug standard code, standard drug code is the key that help us to be able to kind of the reimburse to the provider. And this is incentivize, vice versa, it incentivize them to adopt the Thai medicine terminology without the financing enforcement or the agree on the financing side. It is maybe not possible or very difficult to persuade the provider to use the standard coding like the drug standard. And like Dr. Supasit just explained about there is the more we grow as a universal coverage, there is many variety of the payment system, not just the DRG for the acute care in the IPD and the capitation for the OPD, but it seems like we have more people aging, long-term care, and also the new technology like one-day surgery, something like that. So the spectrum of the care is vary a lot. It cannot be classified as IPD and OPD. Sometimes it's only one-day surgery, and also the chronically care. How we gonna address those? That is come to the several finance model or the reimburse model. And I really exciting to see the paper that Dr. Supasit just demonstrate that many countries not use only one or two model, but combine of many model. And to me, value-based healthcare, the integrated healthcare, the episode-based bundle payment, all of these need a large number of the clinical data to include in the payment system. If we don't know the procedure in detail, if we don't know the laboratory that they was utilized, it's very difficult to come up with all of these model. So to me, that's why I think the three, if you want to decide, like right now, Thailand are struggling with the policy, the populist policy that they will, open up for everyone to go to primary care, like in Taiwan. And then if they don't know, in the morning they go to one clinic, and in the afternoon they go to another one clinic. No gatekeeper. Then how we gonna know that in the morning they already get antibiotic, and in the in the evening they will prescribe the antibiotic also. So health information exchange and the standard and interoperable of the system are the kind of the key to support all of those ambitious policy, the populist policy, like the 30 baht anywhere, or using only ID card to go anywhere, no gatekeepers for primary care. That's what I learned. And so I think, Dr. Supasit is my mentor, and I'm really happy that he used my model to explain in this webinar.
Thank you, Dr. Bunchai. I'd like to check, Dr. Supasit, if there's anything else you'd like to add before we proceed to the next question.
And nothing else.
All right.
That's that's just to.
Our next question is from Dr. Titus. He's asking if Thailand has a national health claims exchange system.
I think it's not perfect yet. Yeah, within one scheme, as we are struggling with the information system, they try to phase in, like in some provinces in Bangkok, they advertise that the provider will know the health information or the electronic medical record, so that we can manage the problem that Dr. Bunchai raised, that what the previous what the morning providers prescribe and delivered to the patients, so that they minimize repetition or the medication possession ratio. So that's just the big word of mouth. And the project quite delay, because of it cannot deliver on this. So that a challenge. What Bunchai want to add?
I just want to respond to Dr. Titus' question. I'm not quite sure about what it means by national health claim exchange system. So when we talk about claim, it maybe you mean the claim information system, right? Behind claim information system, there is several models, right? We can pay by capitation or by the case mix or DRG or the other the skill fee for service or the fee schedule. That is the model behind the claim, which it need the information. So when you said it national health claim exchange system, for the information to create those models, right now, I think we can say that we have the exchange all the three major health insurers in Thailand, that they use the you diagnose it, the ICD, the drug, they use the TMT, and they agree the a data set that they will use to calculate DRG. But each insurer, they have a different model for the beneficiary. So that's why they need, deviate more on the data. So in terms of for the provider side, they have to prepare for the three insurer. But for their health information system, they has data like the foundation data for the claim to create DRG, and also to create a fee for service for the drug or something like that. So to me, I think we can say that we have a national health claim information exchange system, but not perfect. Not like the Taiwanese National Health Security Office, no, National Health Insurance Office in Taiwan, or Korea, something like that. For Solov, I haven't. This is my first time to know that Indian also have the HCX, which is I don't. I would like to learn more about this. But what I learned is that India, they have the identifier and they have the unified payment. But I'm not quite sure that they use a DRG or not. But to me, to my understanding, India has many states, right? And each state has many model of payment. I think last year, one of the state governmental officer come to learn about our DRG system. What I learned is that they're still paper-based. Odisha, right? Ajahn Supasit, is that the Odisha state government come to look at that. So to me, I think for India, there is a spectrum of the maturity of the payment. So I don't quite sure that SCX, this is in which state and what it would like. If you can point me to that resources, I would like to learn more about those two.
Sure, I think Dr. Titus would have more information, but but it's basically allowing different insurers to send standardized claims, and then it would route or different health facilities to just send claims to a central exchange, like in a bank clearinghouse, and then it would route it to different to the respective insurers for reimbursement. No, so that's I think the system that's being worked on in India. But yeah, maybe Dr. Titus knows more about it, but that's my limited knowledge.
I think that's the last question for tonight. Before we wrap up our session, maybe we can hear a few words from Sir Saraf from Open IMIS, and then Professor Supasit and Dr. Bunchai.
Sure. Thank you, Cha. And from my side, just thank you, Dr. Supasit, Dr. Bunchai, for this webinar. No, I think it really helps the wider community, the Open IMIS community, and the wider digital health community working on health financing, to hear from your experiences and to really see to understand the linkage between health service delivery, health financing systems, and health information systems. I think that triangle is very important, and we need to make more people aware of it and make them see the advantages. So thank you very much. And for the rest of the crowd, if you like what you saw in this webinar, please stay tuned to other webinars from AHIN on Open IMIS and other digital health topics. If you want to play around with digital health financing, with things like claims, with managing health insurance schemes, with digital tools, feel free to check out Open IMIS, which is a free digital public good that many countries are also using, but you can also try out some concepts of for yourself to learn and to experience it. So please feel free to go to openimis.org for that. And then if you have any questions, just reach out to Ahin or Open Image would be very happy to answer. So again, thank you very much, and over to Dr. Supasit and Dr. Bunchai.
Yeah. Yeah. Thank you very much for inviting me to join this discussion and to learn more on that, what the situation right now and what we should expect or the should witness in the future. Thank you.
Okay, I will be the last word. I did not hear from Alvin, which is always vocal and then supporting us. Maybe he's busy with some works. But I thank you very much. I think Open Image Ahin has works, and we know that insurance, financing, and also the information system, healthcare are all really in tight link. And then we have to learn all of the three. I'm very lucky that I have Professor Supasit as my teacher to teach me about more the financing. So I understand on many sides of the of the healthcare service system. And thank you for attending this webinar. And I hope that we can have more webinar related to these three components in healthcare system. Then I think Cha would like us to open to turn on our camera so we can take the group picture together.
All right. Thank you.
Okay, thank you. Bye. Good night.